Uh, let's start our session. Um, Good night, my colleagues, and hello everyone. Let's start first session for our colleagues who are aiming to have their viva exam in next March. Let's start with our first candidate. See, as usual, I will start with the case, and during or in between the cases, I'm giving some tips and some advices. Okay, my colleagues. But first of all, stay motivated, whatever happened in the past, because each Viva setting and each exam really has its own circumstance, either for you or from the side of the RCR board. So, in my opinion, think about the present time. Sure, we must learn a lot of lessons from the past, but only lessons. Don't think more and meditate in negative feedbacks or negative circumstance or negative results, because really it will depreciate and it will affect you badly. I'm speaking like this because I didn't pass first exam for me, whatever the cause, but finally I didn't pass. And I have the same or yeah, I have similar bad feedback like many of you. But really, when I throw the past in my back and start to think about the future and how to pass, it was really the true starting point. This is the most important point to start with. Okay, anyway, could you ask for control, candidate one, please? This is 25-year-old female patient. She is complaining of severe anemia, hematochezia, with suspected GIT bleeding. Doctor, go on.
I have been presented with axial images of abdomen CT scan with contrast for patient with history of anemia, hematochezia, and GI bleeding. First, I will take a general look quickly through the images, then I will come back to my observation. I
Yes,
will scroll until the last cut.
yes,
Yeah. Okay, this is the last cut. I noticed that there is telescoping between two bowel lobes seen in the left upper abdomen.
mm-hmm.
Here, if you can see my mouse,
Okay,
I
okay.
can see, yeah, I can see that there is a target sign appearance representing two loops within each other, representing interception. Regarding the rest of the images, I cannot see any small bowel or large colon dilatation. There is no evidence of free gas. Also, in my routine practice, I want also to change this into the lung window. There is no pneumatosis intestinalis, and also there is no gas seen within the liver. There
Yes.
is no gastric or duodenal dilatation.
What else?
Okay, I want to see if there is any other findings. There is fecal impaction noted within the rectum. I'm assessing the rectum area to see if there is any thickening in the wall. I didn't appreciate any. There is no free fluid, no significant lymph node enlargement or fat surrounding could be seen within the abdomen or the pelvis. According to the liver, I can see that there is multiple enhancing lesion noted within the right liver lobe. of variable size.
Yes.
This lesion, I want to also review the other sequence for this patient, such as the venous phase, for better assessment of these liver lesions.
Okay.
To summarize my case, I can see that there is interception noted in the ilium lobes without any significant leading point, and I can see that there is multiple lesions within the liver. In my routine practice, I want also to see the venous phase for better assessment and evaluation.
If there are no any venous phase, what would you do?
I will see the pre-contrast study.
No pre-contrast, only this phase. What is the name of this phase, please?
This is arterial phase.
Which arterial phase?
Um,
How
I,
many arterial phase do you normally have?
yes, we can do which is called double bolus, which is
No, no, no,
giving
no,
contrast
no, 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 no,
image within the vein.
no, no, no. You are talking about something related to kidney, but now I'm talking about the arterial phase.
Yes,
We have more than one arterial phase. Do you know the difference between them or the name of them?
yes, I can think about two: the early arterial phase and late arterial phase.
So, which arterial phase this one?
Which one? I think this is the late
Why?
because I can see that there is enhancing within the both kidneys
Okay.
and enhancing within the ureters and venous.
Okay. What else? You describe multiple hepatic focal lesions. What else?
Okay, I want to see if there is any source of this lesion, such as carcinoid tumor. Also, I want to see if there is any primary lesion. Now I'm looking through the mesentery to see if there is any cellulite calcified lesion, which cannot appreciate. Uh, and
Doctor,
also, I cannot see any
doctor,
massive.
see, you see multiple hepatic enhanced focal lesions. In which
Yes,
phase?
in the late arterial phase.
What does it mean for you?
This lesions is avidly enhancing within the
Yes.
arterial phase.
Yes. What's your differential?
Differential diagnosis. Okay. This could be metastasis.
Yes. Why not
Uh,
HCC, doctor?
HCC, yes, it will show early enhancement and rapid washout, and also adenoma in female patient.
No, 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 no. See. In this arterial
In
only.
this patient, ah,
Do you have
because there
any?
is,
Mm,
ah,
yeah.
this is not likely to be HCC because the liver surface appears smooth and
Okay.
not
Yeah.
so.
So most probably you mentioned this is it may be a metastasis,
Yes,
arterial hyper enhanced metastasis. Which
yes,
which site is the most likely to be the primary? What is
on the right side.
1 minute? 1 minute. Which come in your mind about hyper enhanced arterially enhanced metastasis? What are you thinking about? Hello?
Hello?
Yes. What
Ah,
are you thinking about?
colon cancer could
No,
be.
no.
Ah,
Colon is adenocarcinoma, and I mentioned many times before, most of the adenocarcinomas are not arterially hyperenhanced. What else?
uh, those could be due to choriocarcinoma.
Okay.
this
Else.
could يعني melanoma,
Okay. What else?
RCC,
Okay. What else? But here in this case, you didn't see any RCC.
Yes, I don't. It's generally
So
speaking, yes,
when I asking about differential diagnosis, I asking about this case. So,
yes.
hmm, what do you think? Which are the most important sites to search about the primaries?
Site.
Hmm.
Maybe the urinary bladder or uterus.
Okay, doctor, look here at this slice.
Mhm.
What happened?
Okay, I will look. Um, I'm looking for any evidence of primary lesion.
Yes,
Okay.
this is better, more easier. Look here. What happened here?
Yes, I can see here there is enhancing
Where?
uh, here in the left adnexial area.
No, this is not adnexal. Follow it, please.
Okay, I
Oh.
will follow.
Yeah, go down,
Yeah.
up and down. Yeah. Is this adnex?
Shit. No, no. This is this is looks like a part of the bowel
So
because I
what's
can see
your
that
diagnosis? What's your diagnosis?
maybe carcinoid,
Of?
carcinoid and carcinoid syndrome, which
Okay,
is causing
which
bleeding.
part? Where is the carcinoid here?
Ah, small bowel carcinoid or ileum carcinoid
Okay, complicated by liver.
metastasis.
So your final diagnosis, what's your final diagnosis?
My final diagnosis are those of carcinoid, complicated by carcinoid
Is
syndrome,
carcinoid tumor or syndrome?
carcinoid syndrome,
Why?
because carcinoid syndrome is associated with liver metastasis,
What is the most common complaint of this patient of carcinoid syndrome?
flushing, and
Yes. What else? Yes. Correct.
feeling of hot and
What else?
uh, yeah, wheezing and yeah,
Okay.
uh,
Yes. Okay. If you didn't find this carcinoid here in the ileum and you have hyper enhanced or hyper enhanced arterial enhanced metastasis,
mhm.
what is the other site
For carcinoid
for hyper enhanced metastasis?
rather than carcinoid,
Yes. Which organ we should rule out any tumor in it?
bronchial.
No, I'm giving you a CT abdomen.
I
So
know, no, but thought about bronchial carcinoid. Okay, in the abdomen.
look at this. I'm showing you a retroperitoneal organ is very common with a hyper arterial hyperenhanced tumor, which can cause hyperenhanced metastasis. This
Yes, the pancreas.
what is the name of primary tumor here?
Neuroendocrine tumor.
Thank you so much, doctor. Take some home message. See, when we are talking about differential diagnosis, we want the examiner want the differential related to the presented case. First thing. Second, um, try first to have a look from the beginning till down. Okay? Okay. If you find any pathology, stop and describe and continue. Down, down. Why? Because you start here. Okay, doctor, you listen me.
Yes, yes.
And you talk too much about this less important interception. Why less important? If you remember the history, okay? Remember the history. Bleeding, hematochezia, anemia. Once you see anemia, think about either malignancy or either GIT bleeding, source of bleeding. You have seen this one. Okay, search inside, no any bleeder, no any mass inside. So leave it. Leave it. Search for any other password. You go down, down, down. What happened here, my colleague? Why he confused and didn't see this one? Because this uterus. Okay, my colleague, this is the normal enhancement of the uterus, fundus and walls. Below, from the cervix till down, you will not see this normal avid heterogeneous enhancement. Okay, and this is not adnexal lesion. Okay, so we will go one by one, one by one. Okay, what happened? We didn't see this one. No problem. But you did very well when you saw this multiple hyper enhanced hepatic focal lesion, where number one in this one, caudate lobe, this is the largest. And many times it confused with IVC. Number two in segment six. Okay? You must in your brain analysis the finding. Hyper enhanced metastasis, not HCC, because the liver is regular and healthy. You must tell the examiner. The examiner will not jump inside our brain to search or to assess either we know this is healthy or not, step by step. Okay. Then, my colleagues, please, somebody is using the annotation. Please, please, please don't touch the screen. Okay. Then you have only two differential diagnoses. Only two. Only two, not three. Number one, sorry, what happened? Number one, my colleague, is either pancreatic neuroendocrine tumor. Okay. So I must search the pancreas. I searched the pancreas. So I should tell the examiner, doctor, normal size and enhancement of the pancreas with no abnormal arterial hyper enhancement. Okay. After that, second part, I must go to the right iliac fossa. Why? To search for any carcinoid where in the ileum. Okay, doctor?
Okay.
Okay. What happened? Almost you will find the tumor here. Here. So arterially hyperenhanced tumor, it may be adnexia, but could you think the adnexia can come very anterior and abutting the gallbladder like this? No. Follow it up and down. It is looks like a tubular structure. So it is bowel. If I didn't find any pathology here, go the last chance to the duodenum. Where is the duodenum? Follow the stomach. Follow the pylorus, antrum, okay, and around the head of pancreas. Second part, and then third part. So, in any case of arterially hyper-enhanced metastasis, three sites you must search. I didn't talk about the RCC? Number one, because the patient is very young, 25. Patient is female. Complain is GIT. Okay. Number three, RCC almost. If there are any RCC, almost when you are scrolling up and down, almost you will see it. Very easy. Okay, my colleagues, is it clear? So,
Yes, please.
yeah,
Yeah.
so a chronological speaking is very important. Why in one viva two candidates go? Both of them mention most of the finding. One of them got a high mark, and one may pass, may not pass, because of communication skills, because of chronological thinking. And this communication skills and including the chronological and the critical thinking is very important now. They assess this doctor. Okay, he do like he has a daily practice, one by one, step by step. Okay, I will see there are again. Sorry, I'm repeated because this case is very very typical exam case, which need very too much well organized chronological thinking. I find multiple lesions, So liver healthy, I exclude it, RCC. So this is metastasis. I will go to pancreas. It is normal. I will go to ileum. Ileum, okay, there are hyper enhancing lesions. So it is carcinoid in the ileum, and there are some lesions in the liver. So it is carcinoid syndrome. Patient must have flushing, diarrhea, and mitral, sorry, not mitral, tricuspid regurg. Okay? Okay? So finally, it was a small bowel neuroendocrinal carcinoid, neuroendocrine tumor with liver metastasis. What is the next step? What is your next step, doctor?
PET CT scan,
What?
nuclear study for this patient.
What is the name of nuclear study?
Carcinoid will go with uh, octreotide.
Excellent. Octreotide. Octor.
Octreotide.
Excellent, doctor. Thank you so
Mhm.
much, doctor. Next
Thank you.
candidate. Next candidate. Candidate
Yes,
number
sir.
two. Welcome.
Thank you, sir.
Could you request control, please? 25 year,
I've requested, sir.
yeah, 25-year-old female patient complaining of constipation and para-umbilical pain. Go on.
Mm. I'm unable to scroll.
Scroll upon. Yeah, you are scrolling now. Okay,
Yes, sir. It's scrolling very slowly.
no problem. Go on.
I think I have net issues, so it will just waste everyone's time. I think I won't be able to participate. It's
Do
just
you want me
stuck
to
on
scroll?
one.
Do you want me to scroll for you?
Yes, sir.
I'm scrolling. Yeah, go on.
Okay, this is CT abdomen pelvis axial images with contrast in venous phase.
Yes.
Right now, I'm able to see the liver. No focal liver lesion is seen. No splenic lesion. Kidneys are also unremarkable.
Yes.
Uh, the image is again stuck on the kidneys image.
You can stop me at the slice of interest.
Okay, sir. I can see there is fat staining in the right iliac fossa. No free fluid is seen.
Yes. Do you remember the history, doctor?
So you told that is the patient has periumbilical pain.
And constipation? What is the age of patient?
Okay.
25. Okay. To save the time, please go up. Up.
So the images are not scrolling smoothly for me.
Okay, I'm
This is
scrolling for
definitely
you
a
now.
problem for me.
I'm scrolling for you now. Okay. Yeah. What do you think? Stop me at the slice of interest. See, sometimes the history may be vague, general, misleading. So you are presented with city abdomen. Okay, go on, have a look in each slice. Generally, try to pick up even any subtle abnormality. Could you concentrate in the upper abdomen, please? Okay, doctor.
Yes, sir.
Did you find anything?
So I saw that there was training in the region of around the duodenum,
Yes. What happened? Doctor,
particularly
please.
in the pancreatic
Yeah, yeah.
duodenal groove.
Where?
But but right now I'm not at that image. Like I'm
Describe again the site of abnormality, please.
so I saw that there was fat trending in the region of the pancreatic duodenal groove. The pancreas itself appeared normal without any edematous changes or
Excellent.
swelling.
What's your differential diagnosis?
I'm thinking on the lines of pancreatic duodenal groove pancreatitis.
Okay.
Uh, and so I will convey the findings to the physician, advise serum amylase lipase and CBC correlation, and the patient will need GI consultation.
Okay. What else?
I cannot.
What other? Could you show me which area? By the mouse, please.
Uh,
Show me by the arrow.
yes.
What's your other differential diagnosis rather than groove pancreatitis? What else?
Um, so duodenitis could be a possibility.
What else?
Mm, any possibility of diverticulitis, duodenal diverticulitis,
So
but I cannot appreciate.
what's your next step?
Mm, For first correlation with the amylase lipase levels, and if these are normal,
Doctor,
uh,
see, 1 second.
yes.
When the examiner asks you, means you didn't give him the full answer. You mentioned before
Mm,
this clinical laboratory correlation. So he searched about
mm,
something else, especially we are in radiological exam. So
mm.
in something related to radiology. You did CT and it is not totally conclusive. So what's your next step?
MRI could help. MRI abdomen.
This is the MRI. This is the area of interest. What is the name of this sequence?
Uh, uh, this uh, is this out of phase imaging?
No. Look here to the skin
Yes.
and and out of phase. Do you think out of phase all the soft tissue is very dark like this?
Mm. So, I'm not sure about the sequence. All the viscera
It,
appear
it is
extremely
high,
hypo intense,
high fat. So and
high
low
fat.
CSF. So T1 or T2?
Uh, T2,
High fat and low CSF. T1 or T2?
T1.
T1. There are many types of T1. Here in T1, we completely suppress the soft tissues and keep the peritoneal fat exactly didn't touch it. So I will give you two choices. This is T1 fat only or soft tissue only?
This is T1 fat only.
Fat only, excellent. In T1 fat only, you will any bright thing, it is fat. Okay? Could you concentrate
Yes.
the area of complaint or interest?
And I can see that there is hyperintense signal again in the around the region of pancreatic duodenal groove.
Excellent. What does it mean for you in this sequence?
Uh, the fatty infiltration.
Excellent. How could you confirm it?
Out of phase imaging, it will appear hypointense.
I will give you, okay. Tell me, this in phase or out of phase?
And this is in phase.
Okay. Have a look.
And it appears the area of abnormality appears hyperintense on these sequences.
Okay. This is out of phase. What happened?
Mm, so I'm not okay. Now I can see the out of phase imaging.
Yes.
It still appears hyperintense.
Okay. So, no. Are you sure? You
And
must you see you must ask the examiner to ask him, doctor, uh, please give me two windows. Okay.
okay.
You okay? See, if you ask, give me two window, he must give you. Okay.
Mm, yes.
This is in phase. This is out of phase. See, this is the area
Mm.
of of interest. This one. This is the area of
Yeah.
interest. Hmm. What do you think?
Yes, so it becomes hypointense on the second image.
So finally,
Mm.
what's
So
your
this
final diagnosis?
this is fat in the region of the pancreatic duodenal groove, fatty infiltration.
See. This is the duodenal groove. Look, this is the duodenal groove. This is the superior
Mm.
mesenteric artery and the vein. What is this? What is this? Follow it,
Uh,
please. In the CT, I didn't ask you exactly where is the anatomical location, but here, see, what is this? What is
so this
this?
is pancreas,
Which part of pancreas?
anterior process of the pancreas.
No, this is the anterior process, which below or deep to the vessels. But here, this one which abutted in within the second part of the duodenum head. So, what's your final
Yes.
diagnosis?
So fatty changes in the pancreatic head.
Mimic cancer. Okay. Focal pancreatic
Okay.
lipomatosis mimic neoplasm. This case
Mm.
may be a case of exam. Why not? Why not? Especially, it is one of the differential diagnosis of cancer. In my opinion, if I am examiner, I 50% I can present this case. Why? Because if the radiologist have the enough knowledge, okay, he will
Yes.
save the patient from unnecessary pancreatic, very painful biopsies. Very painful. Okay.
Mm. Yes, sir.
If we have one radiologist that he has good knowledge, especially about the MRI, this is, by the way, T1 fat only. Okay. This is
Yes.
the T1, but this is called Dixon. What is Dixon? This is the technique name. Okay. This is in
Okay.
phase and this is out phase. How can we know both of them? At least out of phase, you can see this chemical shift line, Indian ink line, this one. at the soft tissue fat interface. Very characteristic. Okay. When you are presented with out of phase, be sure that there are in phase. Okay. Before it. Doctor, which type of fat, which type of fat is appreciated or can be assessed in during in phase and out phase? Which type? Hello? Hello? Hello?
Yes, sir. My internet connection was unstable, so I could not hear you.
No problem. Which type of fat can be assessed during in phase and out phase?
Microscopic fat.
Excellent. Uh, Second tip, my colleague, do you know the out of phase is the best sequence to assess the hepatic border? Look, very sharp. Okay, very sharp. The out of phase. Look here,
Yes.
very sharp, straight. Okay, my colleague, if you are
Yes.
in doubt in your normal daily practice about cirrhotic liver or about liver border, bring out of phase. Very sharp, very sharp. Thank you so much. This case was for
Thank you, sir.
pancreatic lipomatosis, mimic neoplasm. Okay, thank you so much. Next candidate,
Yes, sir.
welcome.
Thank you.
55-year-old male patient presented with Leon pain. 1 second. Request control, please.
Requested.
Go on.
Okay. So I've been provided with axial contrast enhanced CT scan abdomen
Yes.
in a 68-year-old patient who has presented with raised ESR. I'm first going to scroll to the topmost cut. This is the topmost cut available. I can see that there is right-sided
Doctor,
hydronephrosis.
your voice is very muffled. Very muffled.
Sorry, sir. Can you hear me now?
Yes, much better. Go on.
Okay. So there is right-sided hydronephrosis,
Mm-hmm.
and I'm going to trace the ureter down
Yeah.
to see if there is any obstruction within the lumen or if there is any extrinsic compression.
Mm-hmm.
Meanwhile, I can also see that there is a soft tissue density rim around the abdominal aorta,
Mm-hmm.
which is extending behind the aorta, between the aorta and the spine. Inferiorly, as I'm tracing the ureter, I would want to see if this is in line with the soft tissue density, and I can see that up till the bifurcation at the level of the right common iliac vessel, I can trace the ureter. Beyond that, I cannot. I can see that the soft tissue rim is also extending inferiorly along the common iliac vessels bilaterally. Um, I would like to look distally. If the ureter is normal in caliber distally, I can see that it is normal, and this is the last cut. So, on the basis of the imaging findings, this most likely represents retroperitoneal fibrosis, which is extending from the bifurcation level up until I would like to know the proximal extent. If this is infrarenal, if it ends below the origin of the renal vessels.
Mm-hmm.
So yes, it is ending before the origin of the renal vessels, and there is encasement or compression of the right-sided ureter by this retroperitoneal fibrosis. This also is in keeping with the raised ESR levels. I do not see any significant hydroureter on the left side. I would also like to look at the pancreas and the biliary system to see if there is an associated IgG4 related pathologies such as autoimmune pancreatitis or biliary cholangitis. Um, and also additional complications, additional organ involvement with IgG4 should be correlated with. I will convey my findings to referring physician. I would suggest correlation with IgG4 levels, and I would also suggest clinical evaluation for involvement of other organ systems, particularly the hepatobiliary system and the involvement of thyroid gland or any other organ system involvement. For this particular patient, since there is the encasement of the ureter and there is hydronephrosis, I would also suggest urology consult for placement of percutaneous nephrostomy.
Yes. Uh, Enumerate different causes of this pathology, please.
So retroperitoneal fibrosis can also be related to primary aortic infection like aortitis. It
Mhm.
can also be related to malignancy such as lymphoma, and any associated inflammatory disorders can result in this process, like this inflammatory soft tissues, like drugs also, like hydrolazine intake. Prolonged hydrolazine intake can result in retroperitoneal fibrosis. Also, if the patient has, I do not see any stigmata of malignancy previously in this region to suggest that there could be a radiation exposure that could result in retroperitoneal fibrosis.
Thank you, doctor. Really, 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 you impressed me. Very nice style. Very, very nice style. I appreciate. See, my colleague, if you remark, I didn't ask her because she gave me all the information once, like a bullet. She start with description and then she put her differential. Okay, and further beyond that, she told me what she will do and what should she should exclude. Okay, except one thing. What is this, doctor? You forget to talk about this one. What is this?
Sir, I'm sorry, I don't know. Retroaortic course of left renal vein.
What does it mean for you?
What does it mean, sir? It could result in nutcracker syndrome. It can result in other.
The patient may complain?
He can complain of loin pain. Can complain of hematuria
Yes,
and varicocele.
excellent. Okay. Thank you, doctor, so much. It was a case of retroperitoneal fibrosis. The different causes start from idiopathic, then infection, post-traumatic, some drugs, and post-radiotherapy. Here, the MRI, I think, the same. You did very well, our colleague, when you talk about the nephrostomy tube. Very important. I'm waiting for you to bypass this one, but you didn't forget. Thank you so much. Doctor, one question. What is the
Yes,
name of
sir.
this sign or what happened for the ureter here?
Uh, the full,
What?
acute angulation, the fish hook sign, or
Yeah, what is the exact name of this acute angulation?
so there is the fish hook sign or J shaped.
Yeah, but medialization, see? Medialization better than Fisher sign because I think Fisher sign related to
Fish
retrocaval
hook sign.
fish
Yes,
hook
sir. It is
sign.
related to retrocaval ureter. Yes.
Yeah, yeah. الfish hook sign related more the name of the sign to
Yes.
the retro caval ureter. Thank you, doctor, so much. It was a case of retroperitoneal fibrosis. You must talk about IgG4. It is a must. Now, since I think 10 years when they discover this, it is very recent disease, by the way. Not since long time. This IgG4 syndrome. It was very nice era, but now it is a disease. It is well known. Hundred of cases are uploaded on the internet, so we must talk about. Okay, IgG4 when you are presented with retroperitoneal fibrosis. Uh, Sometimes, my colleagues, you are presented with pancreatitis and cholangiopathy. Okay, and you must search for retroperitoneal fibrosis. I think I presented since 3 months or more one case like this. Thank you so much. Candidate number 4.
Assalamualaikum, sir.
Alaikum salam. 50-year-old male patient presented with jaundice. Request control, please. Go on.
I am presented with CT, abdomen, axial, arterial phase. I'm scrolling through the images, then I will start describing.
Go on.
There's a bit lag in images.
No, it is scrolling.
Okay, I will come to the last cut. Then I will describe my findings. So images are a bit lagging for me, coming
Okay.
late.
Let me scroll for you.
Okay.
Stop me at the site of interest.
Okay. I want to go to upper cuts of abdomen. Okay. There is dilatation of intra and extra hepatic biliary channels. I want to see the pancreatic region. I can see pancreatic duct is dilated and traceable till the head of pancreas, where there is cystic dilatation.
Yes.
Okay. Sir, can you scroll a bit more up? Okay. So this is CBD, which is also dilated and traceable till the head of pancreas. In pancreatic head, I want to see if there is any um, focal lesion which is causing these dilatation.
Yes.
Can you scroll a bit more, sir, to the head of pancreas? Okay. Yeah, there is a hypodense lesion in the head of pancreas, which is enhancing less than pancreatic parenchyma.
So,
So this appears to be a primary pancreatic mass, which is causing biliary dilatation and pancreatic duct dilatation.
okay. What is your next step?
So yeah, I will advise ERCP to decompress the biliary system and refer this patient to hepatobiliary MDT and advise CA19
What
levels,
what else?
advice biopsy.
What else before biopsy?
ERCP samplings. Or for
ERCP,
confirmation, I can also do MRCP, MRI.
yeah, ERCP is not related to us. We are not
Yeah, yeah,
gastroenterologists. Okay, go on.
yeah. Okay. Okay, there's appreciated dilatation of intra and extrahepatic biliary channels and also head of pancreas, pancreatic duct dilated, and I want to see the head of pancreas, the previously seen hypodense lesion,
Where is the head of pancreas?
which is,
Look, one
uh,
second. Tail,
yeah,
body,
yeah, yeah,
what? Then this is the head. Okay,
yeah, yeah.
go down.
Okay, no lesion is appreciated in these images, and there is distal tapering of CBD.
Where is the mass lesion which you saw in the CT?
Yeah, it's not appreciated here.
Okay, not appreciated in the head of pancreas.
Yeah.
Where? See,
Um,
the dilatation, the double duct dilatation is
double
below,
duct sign
yeah,
up to ampulla. Exactly, ampulla of Vater,
yeah, below the level
ampullary region.
of pancreatic head. So go down
Yeah,
with them. What happened?
yeah, yeah. Okay, there is a um, uh, eccentric thickening of duodenum, which can be the cause of this obstruction.
So what's your diagnosis?
So it's a ampullary mass which is causing biliary dilatation and pancreatic uh, duct dilatation,
How could you confirm it?
ERCP and biopsy.
No, see, we're still in one sequence of MRI.
Yeah, 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 yeah,
Asking
yeah.
me as an
So
examiner.
post contrast, I can see post contrast.
Yes.
Yeah. Okay, there's enhancement of this thickening
Could you
in the medial wall.
by the arrow?
Yeah, this here
I didn't see your
is
mouse.
Crohn's.
Yes, show me.
Yeah, I want to scroll a bit. Yeah, this. Mm, this here.
Where?
Here.
No, no,
Um,
exactly, no.
Left. Mm, I think this is the thickening hole.
Which part? See, 1 second. One
Yeah,
second.
yeah.
Make a circle around it, please. Make a circle. Use the arrow.
This part.
Make a circle and give you the.
Uh, yeah, yeah. This.
No.
Okay.
What else?
Mm, mm, what else can be? Sir, can you scroll?
1 second.
Yeah. There is thickening, eccentric thickening of
Okay,
duodenal wall.
please.
Yeah.
This is the mouse. Show me. Make a circle again.
Yeah, yes, sir. This this is the thickening.
Okay, see? See my mouse? What about
Okay.
this?
Is it diverticular?
1 second, 1 second. What about
Yeah.
this?
Okay, okay, okay.
Very important. Doctor, why? Even you can
Yeah,
guess why. If you look at this one, there are solid hyperenhance. There are cystic changes. Okay? And besides that, if you ask for this one, diffusion, look here. Look.
yeah, there's restriction.
Yeah. See?
Yeah,
All of this is mass.
yeah. Okay.
Okay?
Yeah,
How can we know? Go before and after. Here is very clear by my colleague. This is the third
yeah.
part. This one. See?
Okay.
Sorry, because this is very confusing part. I will
Yeah,
I will make it many times. What happened? This is the third part. This is the third part. Okay? This is third part. But here, this is a mass restricted. We can confirm by EDC. This,
ADC. Yeah.
this is a mass. Even if you compare this lumen by the size of this lumen, very big difference.
Mm,
Market
mm,
expansion here. Okay.
mm.
At least you can ask for others, like here, or like, sorry, like here.
Yeah,
Here, what happened? This is the pylorus first part. Okay. This is the lumen. Look here, all of this.
yeah.
And where is the
Yes.
pancreatic head?
Mhm.
Better in axial. Okay. Anyway, see the mass here is very obvious between the
Yeah,
junction of second and third part. Anyway, my colleague, see, this is the mass. This is the mass. Okay, this is EDC and it shows low EDC. All of this.
mm.
Okay, my colleagues. So, duodenal adenocarcinoma, what is your next step, doctor, in this case?
Yeah, I will advise biopsy and refer this patient to gastroenterology for staging, CT, chest, abdomen, pelvis, and then resection.
Before all of this, do you think this patient can go first to biopsy?
Uh, I will advise ERCP.
Before ERCP, this patient need drainage.
Yeah.
Okay. And
Yeah.
I don't know, he can be drained internally by ERCP or by BTC. At least you must tell the examiner
Yeah.
first, the biliary dilatation must be relieved. Why?
Yes.
Because jaundice, my colleague, and or biliary obstruction affect the bleeding factor so badly. And I think this patient can't go any interventional procedure before drainage and assessing his bleeding profile. Okay, my colleagues. Thank you, doctor, so much.
Thank
Um,
you, sir.
welcome. Do you know the name of operation which should be done for this patient? Patient has duodenal carcinoma like this. What is the name of operation here? Hello?
Whipples they do. Yes, sir.
What?
Whipples they do.
Yes, Whipple. Whipple. He
Yeah.
need remove the duodenum, maybe part of the pancreas, especially the head. Very extensive
Yeah.
operation. Thank you so much.
Thank you, sir.
Welcome. Next candidate.
Hello, sir. Assalamu alaikum.
Salam. Request control. This is 11-year-old patient presented with recurrent chest pain and abdominal pain. Go on. Go on, doctor.
Yes, sir. I'm taking the control. Okay, let
Yes.
me go to the first one. This is axial T2 weighted MRI image of a patient who is 12-year-old and has presented with abdominal pain.
Mhm.
I can see that stomach is there is a well-defined fluid signal intensity cystic lesion in left upper abdomen, causing significant mass effect on surrounding structures,
Mhm.
including spleen, stomach, and I'm going till the last cut. It's taking a bit of time. I can see there's another small fluid pocket anterior to left kidney.
Mhm.
Now coming back to the lesion, it does not show any internal solid component in these images
Mhm.
and no septations. It is well separable from spleen and from stomach as well. It is closely abutting left lobe of liver. Um, there
Mhm.
is some compression and crowding of distal esophagus
Mhm.
in lower mediastinum retrocardiac area with compression and displacement of heart as well. I cannot see any relation with the spinal canal in these images. In my routine practice, I will include part of chest as well and will review this area on sagittal images to look for integrity of diaphragm. Um,
Yes. What else?
and the left adrenal gland is also well separable. Um, there is some edema in the left lateral body wall between the intercostal regions, soft tissues. Um, so it appears to be okay. It is showing a medial beak-like extension up till lesser sac and suprarenal area.
What else?
However, what else? Okay. Um, the signal void of vessels is intact.
Say, doctor, 1 second. The patient has chest pain and abdominal pain. What is this?
So it's a large cystic lesion in left lower part of the chest and upper abdomen.
Okay, what is
It's,
this again?
so now in the coronal images, I can see that it is completely occupying the left hemithorax
So,
and suggestive of a large pleural effusion
okay.
with a defect
Yes, where?
with a defect in left hemidiaphragm in medial part.
So this fluid
So
connected with?
it's with the abdominal cavity. Yes, I'm thinking on the line in a 12-year-old child with no history of trauma. The patient has no history of trauma,
No, no,
so
no. See, look at the
it can
billiard system. Look at the
yeah
billiard
it
system.
can be yeah,
Yes.
lymphatic collection,
What
can be
else?
chylous
What else?
or or it can be
Could you have a look at the pancreas, please?
yes the pancreas. I'm coming back to the level of pancreas.
Mm-hmm.
Yes, it is atrophic and there are dilated pancreatic duct and some filling defects within main pancreatic duct.
Yes.
So it's likely a case of chronic pancreatitis with pancreatic duct calculi and a large pseudocyst extending from abdomen, extending from chest and in through the mediastinum into upper part of abdomen.
Yes.
So
So what
I
is
will correlate this. Yes.
how could you connect between the pleural effusion and the chronic pancreatitis?
Between pleural effusion and chronic pancreatitis, it's
Yes.
not a pleural effusion, it's a pseudocyst. I think it's a large pseudocyst.
No. See, no, no, no. It is within the chest. Within the chest completely.
Yeah.
Look, it is pleural effusion.
Okay.
So, so what is the
Uh,
connection? What is this? Look for this MRCP and tell me.
okay, it's
Hmm.
the connection between the pleural fluid and the pancreatitis, sir.
Yes.
Okay. I will scroll through these images. Mm. So could it be due to the effect of pancreatic enzymes
Yes.
creating a defect in the diaphragm and making a communication with the
Excellent.
pleural fluid?
What is the name of this disease or this diagnosis?
Pleuroper
Yes.
pleuroperitoneal fistula.
Excellent. Again, please.
The pleuroperitoneal fistula because of as a complication of pancreatitis.
Pleuropancreatic fistula.
Actually, I couldn't make any connection between the pancreatic duct and this fluid. That's why I
Okay.
mentioned.
See, but why? Why it is? Leave the mouse 1 second. What is
Okay.
the other explanation? Patient has history and the finding of chronic pancreatitis. Then he have this pleural effusion which is recurrent. Then there are tract, only visible tract here.
Okay.
Can you be sure or approved that there were no tract here and obliterated? We are not sure.
Yeah.
Okay. But
Yeah.
collectively, this is the most logic explanation. Okay.
Okay.
This is the
Okay.
most logic. I don't know what is this. Okay. Anyway, they aspirate the pleural fluid and they find I think high amylase.
Yeah.
Very important. You may be asked this question. What is your next question if you are in doubt about this this pancreaticopleural fistula? I will
Yeah.
aspirate pleural tapping and send to lab. If I
Okay.
found lipase amylase, it is a sure sign of pancreatic pleuropancreatic fistula. Okay, my colleague,
Yeah.
very nice case. pancreatico-pleural fistula, post-pancreatitis, either pancreatitis itself or post-traumatic pancreatitis or even post-pancreatic trauma. Think in whatever possible. Okay, my colleague, especially you find these stones. See what is
Yeah.
it? There are biliary stones here. Look, biliary
Yeah.
stones. So this stones is the cause of pancreatitis, and the pleural effusion is the complication. Thank you, doctor,
Okay.
so much. Next
Thank
candidate.
you.
Um, Next candidate.
Hello, good evening. Assalamu alaikum, sir.
Salam, 60-year-old male patient request control, please. Complaining of acute onset of abdominal distension. Go on, doctor.
Okay, so I
Control.
am presented with
Yeah.
coronal images of 60-year-old male patient who has presented with abdominal pain. I'll just scroll through the images before commenting. I think these are T2 vetted images, and I am just trying to make out. Sorry, can you hear me?
Yes, yes, go on.
Okay, so the liver appears unremarkable. I don't see any focal liver lesion, and look at the pancreas. Take out if I don't see any dilatation as well in the intrahepatic biliary channels. The visualized kidneys appear normal and spleen appear unmarkable. Okay. I think there is a focal hyperintense area which is present along the right paravertebral region, if I can see. In my usual practice, I would like to see it in the other planes if available,
What
and try to make it
which
out
plane?
because on these images, sorry,
Which plane do you?
axial images.
This is
Okay, okay. So on the axial images, I can see this is a focal area of T2 hypointensity, which is involving I think it's part of the caudate lobe of the liver, which appears enlarged and shows T2 hypointensity. And coming back to pancreas, the pancreas appears normal. I can't see any pancreatic mass, and the phlobites appear normal. I don't see any free peritoneal fluid. And so, can you have a look on post-contrast images if I can
oh,
see if
this is
this area is
no.
so,
You can diagnose everything from this axial T2.
right? So on this axial T2 emitted images, I can see there is a focal area of hypointensity which is present involving the caudate lobe of the liver. So my differential for this appearance is a focal fatty infiltration, or it could be a focal mass, a small mass. So to characterize it further, I would like to compare with any previous imaging if available, and take it further with post-contrast images or diffusion-weighted images as well.
What else?
Sorry, what else regarding this lesion?
Yes.
Okay. Because I'm just trying to make out whether I mean the epicenter of the lesion, it looks like to be a part of the liver, or and that is the thing, and it is not showing any associated intrahepatic village and dilatation, and the liver is otherwise not showing any cirrhotic changes. I don't see any other collaterals or which are visible on these images. So
See, doctor, what happened here? Go on.
okay, so these are the arterial phase images of the same patient,
Mm-hmm.
and I can see this abnormality. Sorry, can you scroll? It appears
Mm.
isointense to the liver on these images, and I I don't see any internal score or any
Are you,
enhancing score or
are you happy with
anything.
are you happy with this arterial post contrast images?
There is the image degradation due to movement-related artifact. So I would like to see if I can have any other images uh, to characterize this lesion further, like the portal venous phase or the delayed.
Okay, I think this is. See this one? Mm.
Okay. So on these images, I can see it looks like to be arising from the pancreatic body region, this mass, which is abutting the left, I mean, liver lobe. So I don't see any associated pancreatic ductal dilatation, however.
Doctor, concentrate on the liver, please.
Okay, sorry. So these are the, I think these are the delayed images. And
Which one? Tell me which
and these, sorry,
phase this one? Tell me.
I think this is the portal venous phase.
Okay. So what do you think?
So this mass is not showing in any arterial phase enhancement, and it appears isodense on the portal venous phase as well, and there is no peripheral pruning. So my differential for this could be, I think, less likely to be hepatocellular carcinoma, and more likely it is like
Okay, doctor,
because
look with me. What is this?
this
First,
this is the mass which we are
first of all,
looking at.
I show you this T1. Then this is the abnormality. Okay?
Mhm.
If this mass, it must exert a mass effect. So you will not see this fissure like this. You will not see this crura like this. The IVC will not be patent like this. So this is not mass. This is one of the liver loop. What is the name of this loop? Between the IVC,
Riddle lobe,
caudate loop.
Riddle's lobe.
What? Riddle? No, no, no. Not riddle loop. Caudate loop. What happened for the caudate loop here?
It appears hypertrophic.
Okay, excellent. What come in your mind?
So caudate lobe hypertrophy comes in mind. Budd-Chiari syndrome, which is a possibility, which can cause caudate lobe hypertrophy.
Hmm.
So for this, I need to have a look on the hepatic veins and their
So that is why I ask you, are you happy with this contrast?
yeah. So this liver, because I'm not very good at the MRI of the liver, so that's why
Oh,
I was a bit confused whether should I call it or not. So yeah, I can see there is patchy enhancement of the liver, and liver is not showing loss of normal, enhancement. Very mottled appearance is there. I
what
can't
about the
really
hepatic
appreciate
veins?
the
What about
hepatic, sorry,
what about the hepatic veins?
hepatic veins are obliterated. I can't really appreciate the hepatic veins,
Yeah,
and the
the best,
IVC is also
the best,
very
the best slice to assess the hepatic vein go very high at the liver dome. You must see the
right. Yeah,
three hepatic veins opacified. One,
yeah, yeah.
two, three. All of them are non-opacified. So
Non-opacified. Yes.
yeah, it is another. See my colleague, this one. Okay, this is the right. Okay, this is the left, and I think this is the middle.
Left and the middle.
See them at
Yeah,
all.
yeah.
Beside, so at least we have three signs of Budd-Chiari syndrome: hypertrophic
Yeah.
caudate, okay, non-visualized or thrombosed hepatic vein, and this is heterogeneous, dirty, nutmeg, flip-flop, whatever the name. The examiner,
Mhm.
see, the examiner didn't want or didn't wait from us a very specific sign name. No, no, no. At least to pick up the scenario, to save the patient.
Yeah, yeah.
Okay, this is nutmeg, no problem. Nutmeg or flip-flop or heterogeneous dirty, whatever. So finally, it is a Budd-Chiari syndrome. Okay, doctor.
Mhm.
Okay, my colleagues, Budd-Chiari. What is confusing in this case? It is not frankly obvious. It need somebody who report MRI liver. Okay, and we are not familiar with this. In my opinion, this case may be one of the long cases. Very tricky case. Okay, very tricky
Yeah,
case.
on MRI, but on CT we can pick it up. But yeah, if you are reporting MRI, then it is
All,
something else.
all of us will pick up in the CT, no doubt. Uh, Now, my colleague, if RCR exam concentrate on the life-saving cases, subtle and subtle finding, and atypical cases. Why? If this is if you pick up this Budd-Chiari syndrome in one of the early stage,
Yeah,
maybe the patient is saved. It may affect
yes, yeah,
the course of treatment. Okay. And
yeah.
this is one of the important principle in UK to pick up diseases in the early stage. Thank you, doctor, so much.
Early stages. Yeah, thank you so much. Thank you.
Um, Next candidate.
Good evening.
Evening, 30-year-old request control. 30-year-old
Yes.
male patient presented with postprandial pain and vomiting. Go on.
Okay. So this is a coronal CT of a 30-year-old who has come with a postprandial vomiting and pain, and the study is done in the portal venous phase. Just yeah. Okay, so just looking at the initial, having an initial look, the liver looks normal in outline, and there are some there's some contrast in the transverse colon. So there is a both intravenous as well as oral contrast given to the patient, and the stomach is not distended. It is fluid filled, however not distended. Looking at the rest of the small bowel, which appears normal in caliber, and also I'm looking at the biliary organs, looking at the gallbladder, which appears collapsed and thin-walled, and also looking at the pancreas, which appears normal with normal liver and spleen. Okay, so I haven't identified any cause for patients postprandial pain and vomiting at this point. So I'm looking at the large bowel. So tracing at okay, so right. So looking at the cecum, it appears normal. Okay, there are some small lymph nodes in this region.
Don't worry about
However,
it. Don't worry.
yeah, and looking at the ascending colon,
Yes, what happened?
there are some filling defects which are within the ascending colon.
This is fecal matter.
Say it again, sorry.
Fecal matter. What do you want?
Yeah. And so looking at the rest of the large colon, looks thin-walled, distended, however, with normal okay, so right. So there's a transition point at the pelvis in the where there is a collapse of the sigmoid colon, and
Don't
the
worry
rest of
about it. See. You said something and the examiner about the ascending colon, and the examiner encourage you. Ah, yes, tell me. So concentrate in it. What
okay.
happened around the ascending colon? What happened?
I'm looking at it, but nothing is jumping at me at the.
Look, 1 second. Where is the ascending colon? Look. This one. Okay?
Mhm.
Follow it, follow. The ascending colon itself is normal, but what happened around it? Compare with the descending. Is there are anything lateral here? Any structure lateral to
No, no.
what is this?
I looked at it. I thought it's just the ilium lateral to it.
Yes. What does it mean? Is this normal location or abnormal location?
No, it means that the change in the cecal position because of cecum and ascending colon is medialized.
Yes. So what is the name of this process? Look here. Look. What something come from
So
intraperitoneal?
this is a so it's
Or yeah.
it is a internal hernia.
Yes. Look. Why internal hernia? What happened? Ectopic bowel. The key word in internal hernia, my colleague, ectopic bowel. What mean by ectopic bowel? Abnormal position. What mean by abnormal position? All the small bowel must be or almost intraperitoneal. When it became here lateral in the right paracolic gutter here, it is outside of the peritoneum.
Mhm.
Retroperitoneum. And if you have a look here, this is defect here, very clear here. See, very clear here. Look, this is a swelling sign here. Look. Why there are no proximal bowel dilatation? Because this hernia didn't complicate it. This is just herniation. Okay. There are no impaction, no incarceration, no strangulation. The jejunal loop, all of the proximal bowel loop are normal caliber. So it is an internal hernia where transmesentery here, it come the defect here in this one. Doctor, how can we be sure this is internal hernia? Very easy. Number one, check if there are any history of laparoscopic surgery. Number two, look at the common site. Where? Here, at the lesser sac. Where is the lesser sac? Look at the left lobe and the stomach recess interface. This is the lesser sac. No any small bowel or even large bowel. Okay. What is this? This is the normal colon, by the way. This is the normal location. Number two, look at both sides of the duodenum. Where is the duodenum? This one. This is the second part and the fourth part. Here you must see only the flexure of the colon. Flexure. Okay, no small bowel, no right paraduodenal hernia. Look lateral to the fourth part. Here. You will see collection or some bowel loops like rings here. You must see, look at this one. You must see really the bowel like this here. It is very characteristic, and you will see one neck. Sometimes they may covered by membrane. Okay, so three sites. Number three, there are three sites. Otherwise, search for go. You must see the small bowel in the center and the large bowel at the periphery. Anything other than that, it is internal hernia, like this one. Okay? Down here. Where is the sigmoid colon? This one. Go to the pelvis. This one. Okay? If you saw any collection of a small bowel between the abdominal wall and the colon, it is sure internal hernia. It is clear. Clear, my colleague?
Mhm. Yes.
The internal hernia is one of the very subtle and very confusing part. If you remark, my colleague, if you notice from the beginning, I'm concentrating about the weak point for all of us, the missing point, like liver MRI, like internal hernias. Okay, why? Because this is the value of 1.5 hour listening to this online picture and paying internet bundle. So you must not pay or waste your time for a repeated information. Okay, and by the way, most of the colleague know that this is the style of my lecture to cover the weak point. Thank you, doctor, so much. It was a very difficult case. Don't worry.
Thank you. Thank you. Can I ask, why would the patient present with the upper GI symptoms? There was no small bowel obstruction. Um, so what, or was it a subacute small bowel obstruction which was getting resolved on its own?
At least we find something related to the small bowel.
Hmm.
It is a small bowel, not a large bowel. Okay?
Yeah.
At least
Okay.
see, doctor, I think in most of my viva, at least 50%, the history was irrelevant. My exam, not
I'll
not
bear in mind.
not the exams that I run. No,
Hmm.
I'm talking about my FRCR exams. As I remember, many of the cases the examiner give you very vague history, very general history. Sometimes when you are asking, he told you, don't worry. No, like this. Don't wait from the examiner a full history, especially because some history are leading history. Anyway, don't worry. For all of you, don't worry from the first lecture. This is the usual. Don't worry. Uh, Last candidate.
You.
Last.
Sir, we finished our list.
Okay. Let's see this case. We finish 8 candidate, doctor?
Yes, we finished.
8? I think 6, 7 only.
Yes, so we did 7 candidates.
No problem. See my colleague. I will with my.
I can give it a go. It's all right.
Did you have a chance?
I had a chance, yes.
Okay, sorry. If anyone else wanted to have a chance, no problem. Otherwise, I will answer on my own. Anyone want?
If any one of the candidates who want to volunteer a new
Okay,
candidate, he can go.
no problem. See my.
Yeah, I can go, sir, with this.
Yeah, okay. Doctor, this patient has chronic recurrent abdominal pain. He is 35-year-old.
Yes, sir.
Spot diagnosis, please.
Here yeah.
Hmm.
Here in the central part of the abdomen, I can see there is a teething of the bowel loops is there,
Yes,
and there is some heterogeneous signal intensity lesion is there with some speculations are present.
yes.
So I want to see the rest set of the images and the post contrast images to the enhancement to rule out carcinoid. Yeah. Yes, there is a intense enhancement is noted, and there is teething of the bowel loops. There is speculation, significant desmoplastic reaction with mild angulation in the adjacent bowel loops is there. So it's some mesenteric process is going on. There is some enlarged lymph nodes are there. My main diagnosis for this case, it can be carcinoid. I am looking for any liver metastasis.
Doctor, could you request
Uh,
control, please?
Sir, I am on mobile. I
Okay,
cannot.
I will scroll one by one. Let's start with my advice. For usually, my advice is start with conventional sequence before diffusion or before post contrast. What happened here? What happened?
Uh, Here I can see that there is some angulation of the bowel lobes is there,
Okay,
and there is a bowel wall thickening is there, and fatty proliferation is there in the mesentery.
Yes.
It,
What
it
else?
can be the fibrous. This is the center of the lesion is at the level of terminal ileal bowel lobes. This
Yes.
can be the fibrostenotic disease of the Crohn's.
Mm.
That can be a possibility.
Yes. So, what's your primary diagnosis?
Uh, Putting it all together, there is a thickening in the terminal ileal bowel lobes with luminal narrowing with fatty proliferation, with some angulation of the bowel loops is there. It can be due to fibrostenotic disease of the Crohn's, and there is no evidence of any ascites, no evidence of any lymphadenopathy. So that decrease the possibility of the tuberculosis or lymphoma.
No, doctor. See, doctor. See. You were running in the correct pathway. Okay, why lymphoma? Do you see any mass, any pathological bulky lymph nodes? Look here.
Mm,
What is
No
the
obvious.
what is the most predominant pathology here? Either it mass or tubular thickening.
Tubular thickening is the main
Okay.
problem,
Okay.
main
What
observation.
happened between the bowels here? This is one bowel loop. Okay.
Mm.
What happened? What is this extension between from bowel and bowel? Extension containing
This-
human.
Yeah, this can be enteroenteric fistula said due to the
Yes.
Crohn's disease.
So what's your diagnosis?
This is complicated inflammatory bowel disease,
Yes.
Crohn's disease with enteroenteric fistula formation.
Is this active or not active disease?
Yeah, in this case, there is a mucosal enhancement is there, and there is some comb sign is there. Some vessels are prominent adjacent to it, so it's in the active phase, enhancing region. And I will also check the diffusion weighted images as well.
Yes. Thank you so much. What happened here, it is very near from carcinoid. But before before telling the examiner this carcinoid, have a good look. What happened here? Mainly, this is bowel lobe with marked mural thickening and marked luminal narrowing. Besides that, there are extension containing very thin fluid inside. Connection, making or creating connection, interlobar connections. What is this? Fistula tracts. So this is ileoileal, whatever ileocolic. So these multiple penetrating fistulas between the lobes. Okay?
Yeah.
Please concentrate in the main pathology. There are no mass here, even if you have a look at the post contrast. The contrast is within the lumen itself, mural enhancement. Okay? No discrete mass formation. So this is a Crohn's disease. Crohn's nowadays, my colleague, is divided into either penetrating or non-penetrating. Before I think 2021, it was classified either active or not non-active. But after 2021, new classification penetrating or non-penetrating. Even if you can tell the examiner both of them, then you must ask the examiner. I wanted to see both sacroiliac joint. I wanted to rule out any neoplasm formation, also the biliary system, like this. The Crohn's disease is a skip lesion, very important to be mentioned. Okay, so we
Okay.
must ask the examiner, doctor, I wanted to examine the whole GIT, whole GIT. It is very common to be in the terminal area. Okay, and what is the difference between Crohn's, doctor, and TB? I think TB, yeah, I didn't see in my career fistulas like this in TB. In TB, you will see large hypodense lymph nodes. You will see calcified lymph nodes. And it is affected more the cecum. Can I tell you one secret? In the exam, if the examiner, especially in long cases, will bring you a tuberculous tuberculous of the terminal ileum or even the cecum, he must give you a one slice of the lung is affected. Whatever, calcified lymph node or fibrosis or TB, pneumonia, whatever. Why? Because like this, he put you in the corner. You must make TB as a first differential diagnosis. Okay? Thank you, my colleagues. It was a complex internal fistulas due to Crohn's disease. Thank you for all of you. My advice for all of you, this is don't worry about today performance. This is usual to start with some cases difficult like this. But as there are no enough time, I think only about less than 1.5 months, I wanted to start from the beginning with some difficult trips and cases to show every one of you must revise today's session and see which aspect and which type of examination he is need more and more study. Thank you, Dr. Ali. Thank you for all of you, my colleagues. I will upload this case, this session on my YouTube channel. Goodbye.
Thank you, sir. Good night.
Thank you.